Welcome to the McTox Curriculum, brought to you in collaboration with Western University, the University of British Columbia, and McMaster University. This presentation is part of the McTox Curriculum built for residents and fellows from PGY 1 to 5. This presentation was developed by Dr. Bandar Ba, and the topic is about aspirin and NSAIDs. By the end of this 10 minutes, learners should be able to differentiate between acute versus chronic aspirin toxicity, discuss management plans for aspirin toxicity, and to understand the mechanism and effect of NSAID overdose. Let's start this teaching session for this topic with a case. An 82-year-old woman presents with progressive confusion over 3 days. Her spouse reports that she was fine until a week ago when she started experiencing tinnitus after bouts of diarrhea for a few days. They report that she takes her medications regularly and denies overdose. Her usual medications are aspirin, warfarin, Lasix, lisinopril, and atenolol. Relevant laboratory investigations are shown here. It appears that she has renal impairment and an elevated serum ASA level. Now compare her to our second case. A 26-year-old female presents to your department stating that she took a whole bottle of over-the-counter ASA 6 hours ago because she was upset about exam results. She regrets having done this and is asking for help. She vomited twice a couple of hours ago and is otherwise asymptomatic. What else would you like to know about her ingestion? We need to know the dose of ingested aspirin. She states that it was 325 milligram tablets that she found at home, but she's not sure how much was in the bottle. Based on the worst case scenario, she could have ingested 32.5 grams of aspirin, assuming 100 tablets in the bottle. Her vital signs show that she has started to become symptomatic with tachypnea. Her blood work confirms the story and the diagnosis of acute ASA toxicity. ASA is rapidly absorbed and renally excreted. At therapeutic doses, this elimination follows first-order kinetics. However, at toxic doses, elimination follows zero-order kinetics, and the metabolic pathway becomes saturated. This may prolong the half-life to 15 to 30 hours with toxic doses. ASA, like other NSAIDs, inhibits cyclooxygenase, thus blocking prostaglandin synthesis, which in turn permanently inhibits platelet adhesion. There are 4 different types of acid-base disturbances that can accompany aspirin toxicity. Respiratory alkalosis is a result of direct stimulation of the medullary respiratory center, which increases its sensitivity to pH and CO2, resulting in hyperventilation. Metabolic acidosis is a result of uncoupling of oxidative phosphorylation in the mitochondria. Metabolic alkalosis is a contraction alkalosis, and respiratory acidosis can result in ASA-induced acute lung injury or salicylate-induced pulmonary edema, or respiratory muscle fatigue. These are considered pre-terminal events. The clinical presentation of aspirin toxicity varies depending on the acuity or chronicity of the ingestion and the general condition of the patient. Generally, the presentation begins with tinnitus, hyperventilation, and hyperthermia. GI upset follows, and then vital organ dysfunction, such as altered mental status from acid-base and electrolyte disturbances, as well as cerebral edema, and shortness of breath from pulmonary edema. Indications for urine alkalinization, which we'll discuss shortly, include evidence of significant systemic toxicity, i.e., symptoms in addition to tinnitus, an ASA level greater than 2.5 millimoles per liter, and evidence of acid-base disturbance. There are many theories behind alkalinization of the urine. Ion trapping theory is one. Because salicylates have a low pKa and are renally excreted, when the urine is alkalinized, the ionized form of the salicylates are trapped in the urine, thereby making them unable to cross back into blood, and therefore excreted. Hemodialysis is another management strategy in the case of ASA toxicity. Indications for hemodialysis are as follows: hemodynamic instability, end organ damage, including persistent CNS disturbance, pulmonary edema, congestive heart failure, renal failure, or hepatic compromise with coagulopathy, severe acid-base or electrolyte disturbances despite appropriate treatment, and in the case of acute ASA ingestion, an ASA level greater than 7 millimoles per liter, or in the case of chronic ingestions, ASA level greater than 3 millimoles per liter. Now moving on to our discussion of NSAIDs. NSAIDs, like aspirin, inhibit cyclooxygenase activity. Traditional NSAIDs inhibit both COX-1 and COX-2 isoenzymes. Inhibition of COX-1 can cause gastric ulcers and renal vasoconstriction, in addition to the effects of inhibiting COX-2, i.e., inhibition of platelet aggregation. NSAID overdose is usually not serious. Most are asymptomatic or cause only minor CNS or GI disturbances. However, NSAID overdose can cause severe GI bleeding and renal impairment. The treatment is usually supportive and there is no specific antidote. Review questions. What are the benefits of hemodialysis in ASA toxicity? What are the causes for inability to alkalinize urine despite alkalytic serum?